welcome to 10 Clinical Minutes. I'm Brianna, and today we're going to be talking about code status. So to start off with some logistics, it's really important to discuss code status at every new hospital admission and anytime something changes in a patient's disease course. So this could be a new prognostic indication or a new diagnosis of any sort. And then anytime that you think it's appropriate, anytime that you get a gauge from the patient or from their family that it would be appropriate to have a new code conversation. And all of this knowing that code status can change at any time. Whether this is during a hospital admission, outpatient visits, no matter what, a code status can always change based on the patient's desires. The decision maker is the person who makes the decision about the code status, and generally this is the patient, unless they lack decision-making capacity. And the most important element of being able to have decision-making capacity is that the patient can understand the risks, benefits, and alternatives of any particular intervention and clearly communicate that back to you that they understand the consequences of taking or not taking action on something. If the patient does not have capacity, then the decision maker is their DPOA. This stands for Durable Power of Attorney, and this is a legal designation. So if they have not gone through the legal process and have the legal documents, then that means that there's no DPOA designated. A DPOA can be anyone that the patient wants. They do not have to be a direct family member. They can be a partner that's not married or legally associated, or they can just be a friend or someone that they want to make their decisions. If a DPOA is not designated, then the decision maker is the next of kin. Now, the relationships of who is next of kin in order varies a little bit by state, but in general, usually the next of kin is a spouse if the patient is married. And if they're not married, then it's typically an adult child or a parent or another close relative. Finally, it's really, really important that every code conversation is clear, thorough, and well documented in the electronic medical record so that any caretaker can see what the patient's goals are. So let's start off with the easy one, full code. Full code means that any intervention necessary will be done. The goal of full code is to prolong life by any intervention that's clinically indicated. This is the default code status for anyone that we don't know their code status or we aren't able to get it from them. By default, you want to do anything necessary, including CPR, intubation, the whole works. But in the case that a patient doesn't want absolutely everything done, that's when things can get kind of confusing. So let's start off with some terminology. DNR is a bit of an older term that stood for do not resuscitate. It's a bit more familiar to a lot of people in and outside of medicine, but in the early 2000s, there arose some concerns that the term do not resuscitate would give the impression that resuscitation would be successful, and thus to withhold that would cause a feeling of guilt. In order to more clearly communicate what resuscitation would mean, in 2005, the American Heart Association decided to replace that with the term DNAR, or do not attempt resuscitation. The goal with this change was to be a little bit more clear in the reality of attempting resuscitation without the guarantee that it would actually bring the patient back to life. A third term that is sometimes used is AND, which stands for Allow Natural Death. This term is used in some hospice and palliative care organizations, but it's really not typically used in many hospitals or other acute care facilities. The goal with AND is to better communicate that the patient is affirmatively choosing to allow themselves to die naturally as opposed to having different interventions, but it's really important to still specifically discuss different interventions that the patient would and would not want. So what are some reasons why someone wouldn't want to be full code? If we're in medicine, isn't that our ultimate goal, to prolong life? The key here is that it's really important to consider patient comfort and patient priorities for their functional status and quality of life. A common misconception that's often portrayed by television and movies is that CPR will restore a patient to their prior functional status before the event happened. But in reality, CPR is a very painful intervention that has a very high rate of morbidity. CPR very commonly will cause cracked or bruised ribs, which leaves significant bruising and a lot of pain. That rib-breaking process can also cause lung injury, and there's a significant risk of aspiration during the process. And then a very important element is that the process of CPR and the disease processes that lead to it can often result in anoxic brain injury that can significantly impair the cognitive and functional status of the patient if they're brought back to life from CPR. The success of CPR is also fairly dismal. Depending on the study you look at, about 6.5% to 15% is the long-term survival rate of CPR, and the survival rate to hospital discharge is anywhere from 15% to 20%. And then a really important statistic is that among end-stage cancer patients, the survival rate to hospital discharge is only about 2.2%. So in this patient population in particular, it's extremely important to have honest end-of-life care discussions. So let's move on to some of the particular terms. DNAR-FI means do not attempt resuscitation, full intervention. The goal of FI is to prolong life, but this excludes CPR. So this would be in a patient that wants aggressive care, but they do not want chest compressions. So this would include anything that would require transfer to the ICU, including intubations, cardioversion, or rescue BiPAP. But any of those particular interventions can be specified if the patient does not want them. So maybe the patient is really scared of being shocked in the event of cardiac arrest, and so they really don't want cardioversion, but maybe they're okay with intubation. Or maybe the idea of being on a breathing machine is just not okay with them, but they'd be okay with some rescue BiPAP or vasopressors to help keep their blood pressure up. So any intervention that would require ICU level care must be either full code or DNAR-FI. But within that, a patient can specify any combination of interventions that they would or would not want. In many hospital systems across the country, there's a movement toward having standardized colored armbands, and the standard DNAR-FI armband is purple with white stripes. This is contrasted to DNAR-LI, or limited intervention. The goal of limited intervention is to restore patient function, but it does not include ICU level care. So this would exclude anything like CPR, intubation, pressors, cardioversion, or BiPAP. Now, a patient can have, for example, normal sleeping BiPAP on the floor, but rescue BiPAP would require ICU transfer, and so that would not be included in limited intervention. But this is really important to know that we're still trying to save the patient's life, but just on the floor. So we can do aggressive IV fluid management, antibiotics, other transfusions, any other lab monitoring, things like that, including rapid responses. In fact, it's really important to have a really low threshold to call a rapid response, because with these patients, earlier intervention could mean the difference between life and death, because if it gets to the point that ICU level care is needed, they don't want that. So if we were instead to call a rapid response and intervene earlier, we might be able to reverse their course. In limited intervention code status, it's really important to frequently discuss goals of care and make sure that the patient and the family member understand their status and that their priorities are well communicated to the care team. Among the standardized color armband system, limited intervention is also a purple band with white stripes. Finally, DNAR-CMO stands for Do Not Attempt Resuscitation, Comfort Measures Only. The goal of CMO is to provide and protect comfort. We are managing symptoms. We are not trying to reverse a disease course. So there are no life-prolonging interventions provided here. But we do provide any and all interventions and medications for patient symptoms. This includes pain, shortness of breath, anything that would be disconcerting or uncomfortable for the patient. In CMO, you also can call rapid responses, and it's important to have a low threshold for anyone on the care team, including medical students, nurses, RTs, anyone, to be able to call the physician if they feel like the patient is in distress of any sort, so that we can provide extra care to be able to make the patient more comfortable. A patient can be on CMO for anywhere from a few minutes to a few months. For example, if someone is in the ICU and the decision is made to withdraw care, they might die in a few minutes. Whereas someone with terminal cancer, they might decide to do home hospice or a hospice house, and they may still live for a few more months. Comfort measures only can be administered in the hospital or in another facility or even at home with home hospice. In the standardized color armband system, CMO status is indicated by a solid purple armband. Here's a summary table that I put together just to better communicate the different interventions that fall under each code status. And you'll notice that in the FI column, there's a couple boxes that are halfway colored in, because those are the different interventions that you need to very specifically talk about and clarify with your patient if they want those interventions or not, and then very clearly document all of that in your advanced care planning note in the EMR. So it's one thing to understand code status. It's another thing to be able to have a code discussion with a patient and their family. There's a really good suggested framework that I wanted to go through here that can help you out when you're starting to get used to these types of conversations. The first thing you want to start with is talking about the patient's goals. Is their goal to live longer no matter what? Is their goal to make it just a few weeks to a big life event? Is their goal to be comfortable no matter what? You need to really figure out what their priorities are so that we can orient their medical care around their priorities. Second, you want to educate the patient and their family or other decision makers about the reality of the patient's disease course, their prognosis, and the different benefits and burdens of things like CPR and all the other things that we talk about with code status. Next, you want to provide a recommendation based on your objective medical assessment of the likelihood that these different interventions will help versus harm the patient. And finally, you want to very clearly document all of the discussion and rationale for the conclusion in the patient's chart so that everyone participating in the care of that patient can clearly see what their code status and their desires are. In these conversations, it's critically important to be extremely clear and very honest. You don't want to use euphemisms. So for example, instead of saying passing, go ahead and say dying. Be clear about what is happening. You also don't want to use medical jargon. This is critically important because you want to make sure that the patient understands what you're asking them. So instead of saying intubation, say a tube down your throat for a machine to breathe for you. And instead of saying cardioversion, say electric shock to try and put your heart back into a normal rhythm. And even though most people understand what CPR is, go ahead and say chest compressions that might involve breaking ribs to pump your heart for you while we try and get your heart to come back. It may sound harsh and blunt, but that's because it kind of is, because it's really important that patients make fully informed decisions about what they would and would not want. To make this easier, it's helpful to practice and have a few go-to phrases in your back pocket so that in a moment when it's emotional and you might be kind of overwhelmed, you have go-to phrases that can help you clearly communicate in that setting. Here are some references. If you have any questions or comments, please email us at info@decodingdx.com, and we'll see you next time.